It gives me great pleasure to introduce Associate Professor Olivia Veatch from the University of Kansas, who's going to talk about elucidating the causes and consequences of sleep disturbances in individuals with Prader-Willi. Thank you.
So I actually brought my little timer up here, so I'm going to keep track this way and make sure that I can move the slides. It's the green. Okay. So I was a little bit intimidated to have to go after Dr. Holland there. He's kind of a big deal in the field, but he actually set up my talk pretty nicely. So that was lovely. So I'm a human geneticist. I'm a biomedical informatician. And I actually have a particular interest in sleep problems. And I'm going to explain to you why. But suffice it to say that sleep problems are one of the most prevalent co-occurring conditions in individuals with PWS. This is a study that I did a few years ago. And this was actually pulling data that have been collected over time on what parents report are issues that they see with sleep in their children with Prader-Willi syndrome. And this is just noting that basically every parent reports a problem in some domain of sleep. So something as far as having issues falling asleep, having issues staying asleep, so sleep onset and maintenance insomnia, as well as issues feeling sleepy during the day, which could actually be an issue with circadian rhythms or potentially some narcolepsy. And that has to do with what we know about the hypothalamus and how it is not patterning correctly in the brain. But this is just noting that we're seeing parents say that there's a lot of issues with sleep problems. And so one thing I wanted to do was better understand why that is and how we could potentially understand how to better treat it. And the reason is that I actually hypothesize that sleep problems are a modifiable risk factor, that if you can target treating these, that you can improve not just daytime symptoms, but long-term neurological outcomes and outcomes related to physiological health. And I think that because there's a number of studies, this is actually model systems work, showing that if you sleep deprive mice during what is comparable to the teenage years of a mouse, and then you let them sleep appropriately well into adulthood, they still express issues with social behavior well into adulthood. And that's just a short-term time of sleep deprivation. So this is saying that there may be this critical window during neurodevelopment where the quality and the quantity of sleep and the timing of sleep is truly important to neuroplasticity. This is also a study showing in typically developing adolescents that shorter sleep duration is associated with higher BMIs. So these are individuals who don't have any issues with metabolism and still having shorter amounts of sleep during adolescence relates to having higher BMIs. And then as we know well, and Dr. Holland set up lovely, that brain plasticity and metabolism are also disrupted in PWS. So this makes it especially important to understand how to treat sleep problems early during these courses of neuro and physiological development that are truly important to long-term positive health outcomes. And so finding genetic changes. So one of the things Dr. Holland noted was that there were differences in UPD as far as having risk for psychosis compared to an individual getting their PWS through the deletion. And this has actually been shown in sleep as well. So I'm not going to go into this, but there are these distinct comorbidities that are associated with having different molecular genetic class. And this is a study that was actually looking at polysomnography. So these are the sleep study data. So objective measures demonstrating there seems to be more issues with central apneas and apnea-hypopnea index, which means that there's more severe sleep disordered breathing in individuals who have the deletion subtype. And so since I'm an informatician, I wanted to go into some data that we've been collecting for decades that is existing in our electronic health record system in the US. And one thing I'll say is that in the US, most of these EHR data are for billing purposes. So we have to do things like validate the phenotype and make sure that we're accurately identifying individuals based on diagnostic codes. So that's what we're doing here. I'm just showing you that we looked for Prader-Willi syndrome specific codes as well as prescriptions of growth hormone. And we're able through manual chart reviews to show that we had a pretty good predictive value. So you'll note that there were 70 individuals who screened positive for PWS. 65 of those individuals actually had PWS when we looked in the chart, 5 didn't. I can talk more about why I think that is if anyone's interested. But we also wanted to compare that to people who don't have PWS and see how good our positive and negative predictive values are. And we do a pretty good job on this, even with maybe 5 false positives. And just to note that the individuals with PWS that we were seeing in our healthcare system were about 16 years old at the first diagnostic code and approximately 50-50 male-female. And then also there were more individuals who were reported to have white race. So that means that maybe we're missing some individuals who are not white race, who are not coming in to be seen in our healthcare system. And then the thing that was notable is when I look at all the comorbidities, and this was an example that we saw in the story this morning about all of the sleep studies. So these people, they're coming in to see our physicians at Kansas to get a sleep study. And that was almost half of the data set. So out of 65 individuals, the most common co-occurring diagnosis was sleep apnea. Then we looked further to see if we could pull genetic testing results. These are actually kind of difficult to pull from the electronic health records because they're scanned images that are attached to the record. So we have to do some fancy optical character recognition to try to pull this stuff out. But suffice it to say that we did find that there were a few individuals in our data set out of the 65 that didn't have any result at all in their record, meaning that either it wasn't used to confirm the diagnosis or they had gotten genetic testing done elsewhere. But we did have a breakdown here where you can see of various individuals who had deletions or UPD. I'm calling it non-deletion because we did find a subset that had something called non-deletion PWS methylation positive. So individuals who actually had a subtype confirmed via the genetic test results were younger compared to those with unclear or missing results, which says something about why we're getting genetic testing results for certain people in our healthcare system. And then we wanted to look and see if there was a reason that, or if there were any differences in the subtypes that we were seeing in our records. And it didn't seem like there were as far as age, gender, or race. However, kids with the deletion subtype actually had lower BMIs compared to the non-deletion, the UPDs. All right, and then I wanted to see what were the differences in some of the co-occurring conditions. I'll note that this was not statistically significant at what we generally consider the threshold of p-value of 0.05 or less, but it was still trending toward a potentially significant result in that these sleep apnea diagnoses were possibly more prevalent in the deletion subtypes. And then we were able to pull polysomnography for a number of patients who had sleep studies. And we saw that there was about an average of 7 hours of sleep, which is pretty good to say that we're collecting enough data to understand how sleep looks in these patients. There was no difference. So unlike the previous study that I talked about, there wasn't a difference that we saw in our apnea-hypopnea index, so no severity of OSA seemed different between subtypes. However, every single person pretty much had what we would use to diagnose moderate sleep apnea. Similarly, for the central apneas, again, we didn't see a difference between subtype, but we did see that almost everyone on average had enough central apneas that they would have been diagnosed with central apnea. And those are two different conditions, even though they still result in sleep disordered breathing. So OSA is going to be physiological in the collapse of the airway, and central sleep apnea is where the brain is not regulating correctly with the parasympathetic nervous system. We did see actually a near difference, again, not statistically significant, but hopefully with the larger sample size, we'll be able to have some power for this. And that there were fewer deletion subtypes who were noted in their sleep study to have insomnia, which I thought was quite interesting. And then just to summarize, so we were able to identify EHR from 65 individuals with PWS, and that revealed that sleep apnea was the most common co-occurring condition, potentially more prevalent in individuals with deletions, although the PSG didn't show difference in severity. And then insomnia, which is a completely different sleep problem, was noted to be a little more prevalent in individuals who had UPD compared to deletions. Okay, and so what I'm doing moving forward is to expand into a different institute and evaluate that same approach for trying to identify patients with PWS and try to build larger sample sizes. I would hope at some point I can do this across all the institutes in the US, potentially elsewhere as well, where there are electronic health record systems. And then the other thing I'm very interested in is understanding if a patient with PWS has sleep problems, what else is that associated with? So how does that affect all the other symptoms that you're seeing? And kind of getting back at that hypothesis, if we can better treat the sleep problem, does that help improve other aspects of quality of life and daily life? And that said, I just want to acknowledge all my collaborators on this. I'm acknowledging also a medical doctor. She's a sleep specialist at Vanderbilt who's going to be helping when we start expanding into other studies. And I'd also like to acknowledge my funding. And I'll note that this was also, it's not as much as has been offered here in Australia, but I did get funding from the National Institutes of Health in the United States to support this study. So that was pretty exciting for us as well to get our NIH involved in that. Thank you.
Thank you so much, Associate Professor Veatch. I have to say, biggest takeaway for me is EHR data in the US is primarily collected for billing reasons. That's interesting. That's worth exploring. All right, I am delighted